Let's dive right into this explainer. We're hitting the ultimate high-yield, rapid review for upper limb anatomy today.
The volume is daunting, right? But we'll completely master essential nerves and mnemonics to crush the NEET PG. Here's your study guide: embryology, the brachial plexus blueprint, key mnemonics, and clinical lesions. Let's go. First up, foundations. The upper limb bud actually appears at week 4, completely regulated by Hox genes. Now, this is wild. The limb literally rotates 90 degrees laterally, mapping your anatomy out perfectly. This rotation perfectly positions your preaxial radius and radial artery right across from the postaxial ulna. The clavicle? Total rule breaker. It's horizontal, subcutaneous, and uniquely ossifies right in the membrane. Okay, on to the core blueprint. The brachial plexus forms from ventral rami from C5 down through T1. Want to remember that plexus architecture instantly? Just use this mnemonic. Really tired, drink coffee now. See how that builds? Roots, trunks, divisions, cords, and finally, your nerves. So simple. Next hack for plexus branches, lateral to medial. Just think, my aunt, ragged, my uncle. That's musculocutaneous, axillary, radial, median, and ulnar. Seriously, those are free points on exam day. Now let's apply all this to highly tested clinical scenarios. We're looking at herbs versus clump keys. An upper trunk lesion at C5 and C6. The direct result of that is herbs paralysis. 6 nerves meet at herbs point. Undue separation of the head and shoulder causes this damage. The classic presentation here is the porter's tip hand. The arm is inwardly rotated and completely extended. Contrast that directly with clump keys paralysis. This one strikes the lower trunk at C8 and T1. It's caused by sudden hyperabduction, kind of like grabbing a branch while falling. It creates a claw hand. Here's the crucial point. Clump keys also damages T1 sympathetic fibers, which triggers Horner syndrome. Definitely watch out for the classic triad here: drooping eyelid, constricted pupil, and zero facial sweating. Remember, this limb innervation comes strictly from anterior primary rami, mapping straight onto the thorax. Let's quickly test your attention. Porter's tip deformity occurs due to what specific nerve lesion? Well, if you visualized herbs paralysis and the upper trunk, you are absolutely right. Spot on. So, could you map those exact paralyzed muscles? And what if the middle trunk failed alone? Keep grinding.